Hello and welcome to BunMed, where we discuss concise medical knowledge that you can fit inside of a bun. Today we will be looking at the clinical picture of anemia, so how the symptoms of the disease relates to the pathophysiology, before taking a closer look at the haematinic deficiency causes of anemia, so that of iron, B12 and folate deficiencies, and as well as that, their investigation and management. Great. So now let's actually have a look at anemia again. So anemia, this last time we said, was a total reduction in the amount of hemoglobin we have in circulation. Now, what do we need hemoglobin for, and what does it do? Well, hemoglobin binds to oxygen in the lungs. And after this, it circulates around the body, delivering this oxygen to respiring tissue so they can make ATP. Now let's go back a step. What if we had less hemoglobin? Well, that means we're going to have less oxygen binding, right? And if we have less oxygen binding, we're going to have less ATP. Now let's have a look at this a bit more in a diagram. So here we can see the lungs, okay, which is where we're going to pick up that oxygen. We're going to see the heart being drawn in very soon, which helps to pump the oxygen around the body, or the blood around the body, through the aorta, and then it comes back in through the vena cava. So you can see the deoxygenated blood coming in through the vena cava from the heart to the lungs, then coming back through the lungs to the left side of the heart, before being pumped into the rest of the body through the aorta, and lastly to a respiring skeletal muscle tissue. And this is where we need it, because once respiration occurs, we need the oxygen to make ATP. So what if we didn't have the ATP? What are we going to see? Well, we're going to be fatigued all the time because we're simply not making the energy that we need. Not only that, but after a little bit of exercise, because our muscle isn't able to respire, we're actually going to become tired much more quickly. So therefore, we tend to get a reduced exercise tolerance. Okay, that makes sense, because if we don't have enough energy, a little bit of exercise is going to tire us out significantly more than those who have normal hemoglobin. Okay, now, this lack of oxygen is going to be detected by our lungs. So what's it going to do? It's going to get breathless. Okay, we're going to get breathless because our lungs and our chemoreceptors actually detects this low level of oxygen. Okay, and the way it tries to compensate for this is by increasing our respiratory rate, thereby trying to pick up more oxygen. Now, the heart is also going to try to compensate, because it thinks that the reason this might be happening is because it's not pumping hard and fast enough. So our heart starts to pump harder, and it starts to pump faster. So therefore, people with anemia might actually get palpitations as well, which is essentially an irregular heartbeat or a fast heartbeat. And in general, they're going to just feel so run down and so grummy, because of the fact that they simply don't have enough energy and enough hemoglobin in the system. So that's the sort of general symptoms of anemia. Okay, what might we see, say for instance, on examination and on all sort of the signs? Well, we know that hemoglobin makes the blood red. It's the main component that makes the blood red, right? So what about if we didn't have enough of it, right? What are we going to expect to see? Well, we're going to expect to see some degree of paleness, because we simply don't have enough blood, enough hemoglobin. So pallor of the conjunctival surfaces, okay? We're going to see some odd things as well, such as a beefy red tongue. I'm not entirely sure why this happens, but you tend to get this beefy red term that's known as glossitis. So gloss refers to tongue, itis the inflammation of. We might also get fissures. So these are these vertical streaks and breaks at the side of our mouths, which can be quite painful. And this is something that we call angular, because of the angle they occur at, and chylitis. And again, itis infers the inflammation of. So if we were to draw that onto our diagram, for instance, what we're going to see is we're going to have the mouth there, and it's this break directly at the corners of each mouth. So what we're going to do now is, after we've seen the general signs and symptoms of anemia, is now have a look at the haematinic deficiencies directly. Okay, so let's take a look at iron deficiency anemia. Okay, so where are we going to start? Well, how do we actually get iron into a body? But firstly, how does iron exist? So iron in nature exists as two types. It can either exist as heme iron, which is the more uncommon type, and this is found mainly in red meats and poultry as the Fe2 plus ion, or it may be found more commonly as the non-heme ion, which is known as the Fe3 plus ion. but this one's a lot harder to absorb into our body. But this is found mainly in things like leguminous greens, cashew nuts, lentils, as well as that fortified bread. Now, I just want you to keep into mind that this one is a bit harder to absorb because actually its absorption is slightly different to the process as it goes. So once we eat the iron, it makes its way to our stomach. Now, if it's heme iron, we can absorb that quite easily so that it will make its way down to the small intestine. However, if it's non-heme ion, so the Fe3 plus ion, we actually need to reduce that to the Fe2 plus ion. And this is done by our stomach acid, as well as some other things in there. Now, once it's been reduced, it makes its way back, it makes its way to our small intestine just like heme iron, where in the small intestine, in the duodenum or the jejunum, it's absorbed into our blood. And it's from there it may be made into heme, nails, as well as hair. And the site where all the iron is absorbed is known as the duodenum or the jejunum. Now that we understand how iron comes to be, what could go wrong and why might we be deficient? Well, we simply may not just be eating enough iron, so we have a reduced intake. This occurs in cases of malnutrition, and especially children from a poorer background, sadly. Another thing that might happen is we might fail to reduce our non-heme iron into heme iron. And this may occur if we are not producing enough stomach acid. So in conditions such as atrophic gastritis, where we have less acid production, we can't reduce our iron as effectively, and therefore we get a reduced absorption. Don't worry a great deal about atrophic gastritis, as this is covered better in the gastro modules. What else could go wrong? Well, we could have an issue with the site where iron is actually absorbed, so either the duodenum or the jejunum. So for instance, if we had something like celiac disease, where we have a sensitivity to gluten, and we get complete flattening out of the finger-like projections that are known as villi that absorb this, or if we get really deep ulcerations in the all over our GI tract and things like Crohn's disease, then we have an issue absorbing the iron into our blood. What else could go wrong? Well, now that we've looked at issues with getting iron into our body, what if we're losing iron via the means of blood? So in things like a bowel malignancy, where we're continuously bleeding from the bowel, we tend to lose iron in the form of heme. Where else could we lose iron from? Well, menstruating women lose a huge deal of iron during menstruation. So, premenopausal women, one of the most leading causes, and probably the most leading cause in the developed world, is menstruation. And lastly, where else could we lose the iron from? Well, if we've got a site of bleeding elsewhere, say for instance our stomach, where we have peptic ulcer disease, then we may lose iron from there. And this occurs in patients who may be using things like NSAIDs long term. Let's look at what the consequences are of just not having enough iron in our body. So if we don't have enough iron, we're not going to have enough hemoglobin. So what our bone marrow is going to do is go into overdrive and push out these cells that are not quite ready, which are usually smaller, microcytic hypochromic cells. We might also get oddly formed cells, something we call poikilocytosis. And lastly, we might get cells of all varying sizes, something we called anisocytosis. In terms of the nails, we might get thinning of the nails. So rather than having nice and normal nails like this, we get a dip in the middle of our nails, a process called koilonychia, or in other words, spoon-shaped nails. And lastly, because we need iron to make hair, we might also get hair loss. And to show that these cells are actually hypochromic, so they have less hemoglobin, we color them in a lighter color, so pink, rather than that nice robust red that we're used to. So what kind of symptoms are we going to see from iron deficiency anemia? Well, obviously we're going to see symptoms of anemia that we talked about in the previous section before this. So I'll just put symptoms of anemia. We're also going to see things like hair loss that we just discussed, okay? We're also going to see this thing that we call pruritus, so itching all over the body, which is a recognized thing of iron deficiency anemia. And lastly, we see this very strange thing known as picker syndrome, where the person has a tendency to want to eat odd things such as dirt or ice cubes. What are we going to see on examination? We're going to see signs of anemia that we talked about in the previous section as well. On top of this, we're going to see things, we might see things like, if it's been there for a long time, a koilonychia, which is the spooning of the nails. Now let's move on to the most interesting section. What investigations are we going to do to diagnose this condition? Well, the first thing that we're going to want to do after seeing the anemic symptoms is do a full blood count. And in iron deficiency anemia, we're going to see a low hemoglobin because we don't have enough iron, and we're going to see a low MCV, so the cells are going to be smaller. And this is something that we know as a microcytic anemia. The next thing that we might want to do is do a blood film. And on a blood film, we might see something such as a pencil cell. So this is the oddly shaped cell. So the process that we call poikilocytosis. We might see cells of varying different sizes, so anisocytosis. And as well as that, we are going to see microcytic, so smaller, hypochromic, so paler cells in our blood. The next thing that we really want to do is some iron studies. And in our iron studies, what are we going to see? Well, we're going to see low ferritin. So in our body, iron is stored as ferritin. If we have low ferritin, it means we have low iron. We're going to see low levels of total iron because we simply don't have enough of it. And lastly, we're going to see a very high total iron binding capacity. So what is TIBC? Well, TIBC refers to how quickly iron binds to the transporter protein transferrin. If we don't have enough iron, our iron is going to bind very, very quickly to transferrin when we put some in. So therefore, we get a very high total iron binding capacity. What else might we want to do? Well, if we have iron deficiency anemia in someone like a young gentleman, we might want to consider something like an anti-TTG and total IgA, just to rule out celiac disease. And lastly, in elderly people, postmenopausal women, we might consider an endoscopy just to rule out some malignant causes like bowel cancer. So what is the treatment for iron deficiency anemia? Well, the first thing we want to do is address the underlying cause. What do I mean by this? Well, if they're on NSAIDs, stop them taking NSAIDs. If they have celiac disease, address that by stopping the gluten intake. Next thing we want to do is update or refill their iron levels, and we can do this with iron tablets such as ferrous sulfate tablets. In the UK, we use this at 200 milligrams 2 to 3 times a day. Another option is something called ferrous fumarate, and we give this at a rate of roughly 280 milligrams twice a day by mouth as well, 2 or 3 times a day by mouth. What are some side effects? Well, because we're taking iron tablets, patients often complaining of black stools, constipation, as well as some abdominal pain and general abdominal discomfort. So that includes part one of Haematinc. I've just split this into two parts just to make it a bit more digestible. Otherwise, the video did get to about 26 minutes, which is rather long. At the end of the second part, I'll try to include some MCQs and some exam style questions just to apply what we've learned so far. But thank you for checking out part one.